psychiatry, Professor Chappell, Mr. and Mrs. Doshi for your hospitality, and to LMU for giving us an opportunity to have this conversation, which has been a difficult one to have during the pandemic. And for reasons that Jay already described, it's been hard for people that have differences of opinion on COVID policy to stand up in a place like this in an academic context and have a meaningful discussion about it. It's been very hard for us to criticize pandemic policies that were favored by the ruling class or by the government. So I'm not going to talk really about myself, but just one or two lines to give you some background on where I'm coming from. So I was at UCI School of Medicine, a professor in the School of Medicine Department of Psychiatry, where I also served as director of the medical ethics program. So I was there for 15 years, basically my entire career since residency training. And I was deeply involved in pandemic policies. So our vaccine allocation policy, where I advocated, give it to the old people first, not to the people who are on the front lines, because I knew the science about risk. But then when our university published its vaccine mandate, the work group that I was involved in that had drafted all the other pandemic policies was not consulted. And I found that very puzzling. And I also found the vaccine mandate to run contrary to the medical ethics principles that I had taught students for many years. So I likewise published a piece in the Wall Street Journal in early 2021, basically arguing that university vaccine mandates violated basic principles of medical ethics. UC went forward with its vaccine mandate. I ended up challenging that mandate in federal court on constitutional grounds. That case is still in federal court in the Ninth Circuit. In response to my legal challenge, the university fired me last December. So I'm now in private practice, but still making trouble. But it's a great honor to be here, mostly because of just the regard that I have for what Professor Bhattacharya and his colleagues, Mark Koldorf and Dr. Gupta, did during the pandemic, which helped to orient me, because I was thinking all of the things that they eventually published in the Great Barrington Declaration, but I didn't know how to articulate it. My background was not so much in public health and epidemiology, more in medical ethics as it applies in a clinical context, difficult cases at the bedside and so forth. But what I want to do in my 10 or 15 minutes of commentary on Jay's presentation is to sort of Google Earth up and try to provide a broader historical, social, and political context to understand what happened during lockdowns. Because I think that broader context and trying to situate this historically is one of the things that we have not yet done and have not yet come to terms with. From the lepers of the Old Testament to the plague of Justinian in ancient Rome, which some historians believe played a major role in the fall of the Roman Empire, to the 1918 Spanish flu pandemic, COVID represented the first time ever in the history of managing pandemics that we locked down, that we quarantined healthy populations. And there was an effort to conflate lockdowns with earlier methods of quarantine that I think are either historically misinformed or disingenuous. While the ancients didn't understand the mechanisms of infectious disease, they obviously knew nothing about viruses and bacteria in ancient times. They nevertheless figured out many ways to mitigate the spread of contagion during epidemics. Time-tested measures range from isolating symptomatic individuals to sometimes closing the gates or locking the borders of walled cities to avoid people coming in and out, to having people who had recovered from the illness and had natural immunity caring for the sick because they were less likely to get sick and less likely to spread the illness. Lockdowns were never a part of conventional public health measures. Jay alluded to this, but I want to make this clear from a very broad historical perspective. We didn't do this before 2020. I believe we didn't do it because it doesn't work. And hopefully you're either convinced of that or at least more skeptical of the notion that it was effective. There was an article published in the New York Times very early on when the White House basically decided that lockdowns were the way to go. This is in February of 2020, where the Times lead science reporter, a man named Donald McNeil, basically made the argument in the New York Times pages and the podcast that was published the day before that civil liberties would have to be suspended if we were going to get a handle on COVID and avoid massive casualties. And the headline of his article was, "To take on the coronavirus, go medieval on it." The article didn't give enough credit to medieval society, which, as I said, sometimes locked the gates of walled city or quarantined sick people who were symptomatic, but never ordered people to stay in their homes, never stopped people from plying their trades, right? The blacksmith could still go into his workshop and make a living, and never isolated asymptomatic individuals. So no, the lockdowns were not a medieval throwback. They were an entirely modern invention, wholly untested on actual human populations and based, as Dr. Bhattacharya suggested, entirely on computer modeling. Alexis de Tocqueville, that great commentator on democracy in America, warned us that democratic institutions and nations contain some built-in vulnerabilities that can lead even open democratic societies to deteriorate into despotism under certain conditions. I would suggest that new levels of political irresponsibility in Europe and America came when we took an authoritarian communist state as the model for managing the pandemic. The origin of lockdowns was Wuhan, China. And the first advocates of the lockdown model were the Chinese Communist Party, at least at the political level. The CCP convinced Western nations that they had stamped out COVID in Wuhan and surrounding regions by a very stringent lockdown. This was utterly false advertising. And if you've been paying attention to the more recent kind of horrifying lockdowns in Shanghai, you know that this was not true. But Italy bought it. After Italy locked down, the US locked down shortly thereafter. And once the US locked down, basically virtually every country in the world followed suit, including poor nations that were in no shape to try to do this to their population. Within weeks, the whole world was locked down. It's one of the fascinating things about COVID was just how global and uniform the response was, with very few, with a few notable exceptions here and there, but for the most part, very few countries that took radically different approaches. So the first thing I want to impress upon you is just the sheer novelty of what happened in March of 2020 around the world. We were introduced, I would suggest, not just to new and previously untested methods of trying to control an infection. More than this, we embraced a wholly new paradigm for society, a paradigm that had actually been decades in the making, that goes back to probably the year 2001, but had never actually been tried prior to 2020. What descended on us was not just a novel virus, but a new method of social control, what I have called the biomedical security state, our quote unquote new abnormal. Biomedical security state involves a kind of unholy welding or melding of three things. The first is public health. The second is digital methods of surveillance and control that were used, for example, with vaccine passports and vaccine mandates. And the third is the police powers of the state, right? The guy out on his paddleboard who actually gets arrested because he's not following public health orders. The term lockdown itself originated not in medicine, but in the penal system, right? The most highly surveilled and controlled setting on the planet goes into lockdown when there's a riot, when there's complete chaos and violence erupting. A stringent response is necessary to restore order. This biosecurity paradigm began to emerge about 20 years ago, around the year 2001, in the wake of the September 11th attacks, the anniversary of which we just observed the other day. Prior to that, biomedical security, paying attention to threats either from man-made or naturally occurring viruses was sort of a marginal part of international relations. It was a marginal part of national defense, right? There was not a lot of talk prior to September 11th of needing a massive infrastructure to deal with a biological attack, for example. It assumed a more central role in political strategies and calculations following 9/11. 4 years later, already back in 2005, for example, the WHO, World Health Organization, grossly overpredicted that the avian influenza, the bird flu, would kill somewhere between 2 and 50 million people. To prevent this impending disaster, the WHO actually made a recommendation back in 2005 that no nation was politically prepared to accept at the time, and probably were not technologically prepared to try, which included the proposal of population-wide lockdowns. So this notion had been floated in public health by 2005. Even earlier, back in 2001, a man named Richard Hatchett, who was a member of the CIA, also served on George W. Bush's National Security Council, was already recommending obligatory confinement for the entire population in response to potential biological threats. Dr. Hatchett is still around. In fact, he's directing something called the Coalition for Epidemic Preparedness and Innovations, CEPI, which is an influential entity coordinating vaccine investment. It collaborates with the pharmaceutical industry, the World Economic Forum, and the Gates Foundation. Like many other public health officials today, Hatchett regards the fight against COVID-19 as a war, analogous to the war on terror. And with war and a wartime response, it's all hands on deck. It's commandeering the entire population to move in the same direction because the threat to us is existential, right? Although proposals for lockdowns were circulating by 2005 and even a little bit earlier in some circles of national security and CIA and so forth, as I said, we didn't embrace this until 2020. At which point we adopted a paradigm that had 3 basic components to it. Again, what I've called the biomedical security paradigm, 3 basic characteristics. Number 1, we formulate public health measures based on possible risks in hypothetical scenarios, computer models, with data presented to promote behavior that would be required to manage a really extreme situation, right? So we present, and this is the second feature, we present sort of worst case logic as key to our approach, a key element of political rationality. And as a consequence of these 2 things, number 3, we need a systematic organization of the entire body of citizens to reinforce adhesion to government regulations and government institutions. Try to dissent from what's being recommended by public health officials, and it could cost you your job, or it certainly would cost you your reputation. You'll become, you go from being a Stanford professor to a quote unquote fringe epidemiologist. Well, this is precisely what happened in early 2020. Number 1, lockdowns were formulated on the basis of worst case scenario modeling. The model used was from the Imperial College in London. This failed model predicted 2.2 million immediate deaths in the United States within months if we did not lock down. And consequently, number 3, the entire body of citizens as a manifestation of civic spirit, right? Nobody wants to kill grandma. We gave up rights and freedoms that were not relinquished, for example, even by the citizens of London during the bombing of the city in World War II. London had curfews, but never locked down during the German raids. The biomedical security state has proven to be far more effective at controlling populations than anything previously attempted by Western nations. Jay alluded to this at the beginning of his lecture, but again, I think it's important to try to put what happened to us in context. Many of us are still sort of shell-shocked from what happened. And so let's stand back and get some critical distance from it and try to understand it. Under this regime, the total cessation of every form of political activity and social relationship became the ultimate act of civic participation. Do your duty as a citizen by completely withholding yourself from public life. It's a very strange kind of contradiction. Neither the pre-war fascist government in Italy under Mussolini, nor the communist nations after World War II ever dreamed of implementing the kind of restrictions that we saw during COVID. I think it's helpful to reflect on the term social distancing, which is not really a medical term. A medical or scientific paradigm would have perhaps deployed a term like physical distancing or personal distancing, but not social distancing. The word suggests that this is a new model for society, a new model for social relationships, one that limits them by 6 feet of space and a mask that covers the face, which is our very locus of interpersonal communication and connection. The 6 foot or 2 meter distancing rule was premised on the idea that was promoted early on that COVID was spread through respiratory droplets, right? When you cough or you sneeze, it could land on someone and be a source of contagion. But one of the things that puzzled me very early on is even when it became clear that COVID was not spread by that method, it was spread through aerosolized mechanisms, we still continued the 6 foot, there were things on the ground showing us where we could stand, or in the corners of elevators. One of my favorite pictures of the pandemic is 4 people standing at 4 corners of the elevator, all facing the corner like this. That won't stop the spread of COVID, right? The total number of people in the room and the total time spent in the room will determine contagion. So rather than putting up plastic barriers everywhere, which impede ventilation, we should have opened all the windows or held class outside if there were vulnerable populations that we were trying to protect. So we were doing all kinds of crazy things that didn't make epidemiological or scientific sense, which suggests to me that they served some other social or political function. The myth of asymptomatic spread was another element that was debunked early on scientifically, but that never sort of translated into public health recommendations or what most people thought they knew about COVID. So the idea that every other person out there is a potential threat to my existence, even if they're not exhibiting any symptoms. It would be hard to devise a better method than this myth of asymptomatic spread, combined with the practice of quarantining healthy people, to destroy the fabric of society and to divide us. And if we look around now, regardless of what we think about the policies or what we think about what happened during COVID or which sides of these debates we might land on, I think all of us can agree that there are deep social divisions. There were deep social divisions prior to the pandemic, obviously politically and socially and culturally and ethically and so forth. But I think we're certainly worse off now than we were 3 years ago. Even families, deeply divided over COVID policy that impacted Thanksgiving gatherings, that impacted, whether or not someone could see their nephew or their niece for 3 years and so forth. In those dizzying early days of 2020, I would suggest we lived through the swift and sustained abolition of public spaces and the squeezing even of private ones. Physical human presence was confined to the enclosure of domestic walls, and even that was discouraged at times. You'll remember our governor and our president discouraging family Thanksgiving gatherings, for example. I think it's important to consider, and certainly I think the context of this lecture with the support of the Bridge Building Program, the Department of Theology, is very important to consider the human and spiritual goods that were sacrificed in what I think Professor Bhattacharya regard as a failed attempt to manage the virus. Friendships, holidays with family, work, visiting and providing spiritual care to the sick and the dying, worshiping God, practicing communal rites of religion and worship, even burying the dead. And by burying the dead, I don't just mean going to a funeral. I mean, literally, there was a few months early on in the pandemic where hospitals would not return the body of a deceased person, if he or she died of COVID, to the family for burial. The body was cremated before the remains were returned, even if the person was requesting not cremation, but let's say a traditional Christian burial. Recall one family at UC Irvine that I was consulted on as the ethicist, where this would, we had to first of all help them come to terms with the fact that their loved one was irretrievably dying of COVID, which was hard enough. And then when they asked for help with the funeral arrangements, the social worker informed them that because of some theoretical risk of that maybe a dead body could spread COVID, a notion that we had no scientific evidence for, and no evidence from the history of respiratory illnesses to believe it might be a risk. On the basis of this theoretical biological risk, a real present known human and spiritual good was sacrificed, right? So there was this very strange reversal of values that occurred. Dr. Bhattacharya, and I'll close with just a couple of last remarks on the effects on individuals in terms of loneliness that the lockdown policies created. Loneliness and social fragmentation were endemic in the West even prior to coronavirus in 2019. In fact, our Surgeon General, Vivek Murthy, was talking in 2018 about this epidemic of loneliness and comparing the adverse health effects of loneliness to the effects of smoking and heart disease. Two researchers, one of whom was awarded the Nobel Prize, Ann Case and Angus Deaton at Princeton, had demonstrated that these factors were contributing to rising what are called deaths of despair, death by suicide, alcohol and drug-related illnesses. So this was an epidemic prior to the pandemic. And the pandemic threw gasoline on that fire. And we could get into the statistics on that during the Q&A if people are interested, but we saw a massive rise last year in drug and alcohol related deaths on top of a situation where that was already a national crisis. This shouldn't have surprised us. Loneliness can kill every bit as much as a virus can kill. And it can kill people that are vulnerable to the virus too. So the idea that isolating elderly people who have a higher risk of fatality from COVID is going to improve their risk of dying, well, that's a complicated question. It's a question that at least requires debate and discussion and a more careful look at the evidence. It's no accident that one of the most severe punishments we can inflict on prisoners is solitary confinement. It's a condition that eventually will lead, if it lasts long enough, to sensory disintegration and psychosis. People lose their minds when we're hardwired to connect with other human beings. And we really can't function. And literally we can't live without those connections for prolonged periods of time. I think this is something that most of the, I would say all of the great religious traditions in the world, both East and West, recognize that need for deep connection with other people and deep connection to the transcendent or to God. So with that, I'm going to close my remarks and thank you again for the invitation to comment on Professor Bhattacharya's presentation.